Hello, and thank you for joining us. It's Spasticity Awareness Week, and you're listening to a special program hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Casey Minnis, Director of Communications for MS Focus, and I'm joined by our Senior Medical Advisor, Dr. Ben Thrower. Please note, Dr. Thrower is not using slides for this presentation, but if you are connected on the Internet or if you would like to ask questions during the Q&A session following this program, we encourage you to connect and use the chat feature. In order to do that, you go to readytalk.com and join with the access code 7766805. That's readytalk.com and access code 7766805. And I'll repeat that before we take questions. Now, allow me to tell you a bit about our speaker. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta. He previously served as the Medical Director of the Holy Name MS Center in Spokane, Washington. As I mentioned previously, Dr. Thrower is also the Senior Medical Advisor for the Multiple Sclerosis Foundation and a regular contributor to our quarterly magazine. And he participates actively in clinical research, serving as the principal investigator on more than 50 trials of MS therapies. Dr. Ben, thank you for being with us, and I'll turn it over to you.
Thank you so much, Casey, and thank you to everyone at home who's listening in. This is one of the topics that I really enjoy speaking about because it's something that sometimes doesn't get probably as much attention as it really should, and that's the subject of spasticity. Spasticity is the result of an injury to the central nervous system, the brain or the spinal cord. So while it's something we certainly see in multiple sclerosis, it can also be seen with stroke, spinal cord injury, cerebral palsy, really anything that bothers the central nervous system or the brain and spinal cord. The term itself, spasticity, is really a very, very old one. It's derived from Greek spastikos, which means to pull or tug. And spasticity sort of comes in a couple of different versions. There is the chronic state of too much muscle tone or spasticity, and then if you have a wave of it, that's called a spasm. All of that is in the family of spasticity. The way that the central nervous system controls muscle tone is a balance between muscle flexion and muscle extension. When something bothers the central nervous system, and tonight we're really focusing on multiple sclerosis, it disturbs that balance. And what that looks like typically in the legs is too much extensor tone. The legs want to stiffen out and go straight. What it looks like in the arms is too much flexor tone. So all the joints, especially the elbows and the wrists and the fingers, want to curl up. So this is not the normal state. Again, normally there's this nice balance between flexion and extension, and spasticity is, again, a sort of a disruption in that normal balance. When we say spasticity, you would think that is always a bad thing. And we're going to talk about evaluating and treating spasticity. And one thing we need to realize before, or for me as a neurologist or any healthcare provider, before we aggressively treat spasticity, we have to realize that not all spasticity is bad. So if you have a little bit of increased tone in your extensor muscles of your legs, so your legs are wanting to straighten out, you might actually be using that in your daily life. So if you have weakness in your legs and when you go to stand up, the legs want to stiffen out a little bit, for, say, someone using a wheelchair, maybe they're using that to help transfer. There's an example or time when that can be excessive. So if that extensor tone in the legs when you go to stand up then doesn't relax, and now you're in your car and your legs are still stiffened out so you can't bend your knees and put your legs comfortably in the car, well, that's a problem at that point. Some of the other potential positives of spasticity may be a decreased tendency towards blood clots if the muscles are a little bit on the tight side, so that can actually be a good thing as well. Obviously, there could be a lot of bad that could go along with spasticity. If you have waves of increased muscle tone or spasm, those can be very painful. one of the cruel tricks of muscle spasms is that a lot of times they act up primarily at night. So just when you're trying to relax and go to sleep, now your legs are twitching and jumping and spasming and really interrupting and your sleep and keeping you from having good energy levels, or at least better energy levels in the daytime. Spasms and spasticity can interfere greatly with activities of daily living. So if your legs are excessively stiff and straightened out, well, then you're driving your foot into the floor, so that can feel like weakness. You can't get your foot up off the floor because it's just being driven down by too much muscle tone. Too much muscle tone in the legs can also cause scissoring, where one leg crosses over the other, so that when the person tries to take a step, they literally may trip themselves because one foot is in front of the other in an abnormal way. That excessive scissoring can also make it difficult for daily hygiene. So if we have someone who's trying to do self-catheterizations or just clean themselves up after going to the bathroom, if your legs are crossing over one another, that makes it really difficult to take care of just daily activities. Another thing that we see with too much muscle tone is something called clonus. And this is kind of a bouncy leg. So if you get your foot in just the right position, usually when you're seated, the leg starts just rhythmically bouncing up and down. And that can range from a curious nuisance to really, really annoying and sometimes even painful for people. So there is a lot of potential bad that can go along with spasticity. When we think about managing spasticity and spasms, there is a ladder approach from very easy, no medications involved, to more aggressive treatments. On the bottom rung of that ladder is removing noxious stimuli. And when we say noxious stimuli, we mean something that's just bothering you. This could be a seating situation that's uncomfortable. Maybe you have a cushion that's pushing on your leg in a long way. Maybe it's a shoe that's too tight. Maybe you've developed a pressure sore, bed sore, or on your bottom or on your heel. That sore can serve as a source of worsening your spasticity. Bladder infections would be probably one of the most common noxious stimuli that we see that really kicks off spasticity. So if we have someone that's cruising along at a certain level of functioning, and all of a sudden their spasticity and maybe their weakness just goes off the charts, one of the first things that we do is look for signs of a bladder infection. For many people with MS, their sign of a bladder infection is not urological, it's neurological. So even though you may not have burning with urination or a change in urinary frequency or even urine appearance, it's not unreasonable to look at the bladder and make sure there's not a little infection brewing there, because that's an easy fix. So if we've ruled out noxious stimuli, the next step up on the ladder would be rehabilitation. We use our physical therapists and our occupational therapists a lot in managing spasticity. And one of the things that the therapists help us do is get a gauge on whether you may actually be using some of that increased muscle tone in a good way to take care of activities of daily living. But one of the things a physical therapist and occupational therapists will do is set you up with range of motion exercises. When we think of exercise, probably very few of us get enough, me included. But if we're going to skip a form of exercise, usually it's stretching, and we're probably all guilty of that. So when we think of exercise, there's strength training, there's cardiovascular, but that third leg of the stool is stretching. And for a person with multiple sclerosis, that third leg of the stool, the stretching is just as important, and for some people maybe even more important than the other two legs of the stool. So getting yourself a good range of motion, a stretching program, is going to be a vital part of that second step in the ladder. We're going to come back to some more aggressive things that physical therapists might do, but usually with the first visit with physical therapists, they're going to look at range of motion, stretching exercises, see if we might manage your spasticity just through those first two steps on the ladder, and maybe we don't have to go any further into thinking about medications. For many people with MS who are dealing with spasticity, they do need to go up to that third step, and that's where we start looking at oral medications to manage increased muscle tone. The two most commonly used medications are baclofen and tizanidine. The trade name of, or brand name of tizanidine is Zanaflex. Baclofen is our old standby. It's been around forever. It does work for most people. We always say that if we get enough baclofen into someone, we're probably going to get rid of their spasticity. The problem is we also may do some bad things that we're not trying to do. So the bad that we don't want to see with baclofen would be sedation. We're not trying to knock you out. We don't want to control your muscle spasticity, but have you asleep all of the time. And we also don't want to make you like a rag doll, too weak and floppy. Sometimes with baclofen, as we go up on the dose, we run into that where someone says, nope, and the legs are not twitching and jumping, my arms are looser, but now I'm just like a rag doll, and maybe I'm less functional than I was when I had a little bit of spasticity. The key with baclofen is to start with a low dose and go very slowly with it. We want to slowly go up on the dose until we either run into side effects or we have the symptoms under control in a way that you're happy with that. One of the important take-home messages with baclofen is that if you are on a regular dose of baclofen, you never want to cold turkey and stop that drug abruptly. There is some seizure risk if you go from a regular maintenance dose of baclofen to nothing whatsoever. So if you're going to come off the drug, work with your healthcare provider, come up with a plan for coming down off of the medicine slowly. If you're just taking a bedtime dose of baclofen, that's different. A low bedtime dose of baclofen, that can usually be stopped without having to slowly taper off of it. Tizanidine or Zanaflex is another commonly used anti-spasticity medication. It has a different mechanism of action from baclofen, and it's not that we can say one's clearly better than the other. It's just that they are different, and one may be better for you individually than the other. They sometimes are used in combination because they work differently. They do hit the problem from different angles, so some people will end up on both medications. We have to be careful with tizanidine in the same way that we are with baclofen, in that we don't want to make you sedated, so we start with a low dose, ease you into it. The other precaution with tizanidine when you first start the medication is be careful when you go from a sitting or lying to a sitting to standing position. We have to make sure that you don't get lightheaded. Tizanidine is in the same family of drugs as clonidine. Clonidine is an antihypertensive drug, and sometimes tizanidine will lower the blood pressure where we really don't want it to. So when you first start tizanidine, if you get up in the middle of the night, it's a good idea maybe sit on the edge of the bed, make sure you're not lightheaded, and then when you stand up, again, make sure that you're not lightheaded before you take a few steps. Other medications that we sometimes look at for spasticity, there's another old drug called Dantrium or Dantrolene. This is an interesting one. It's not something that we use a lot of in the multiple sclerosis world. At Shepherd Center, where I work at, our rehab doctors also manage a lot of individuals who've had a spinal cord injury or a brain injury. Interestingly, Dantrium or Dantrolene seems to work really well in spasticity related to spinal cord injuries. And for reasons I'm not really clear on, it doesn't seem to work as well in our individuals. But it is still in the toolbox, and it may be right for certain individuals. So it's certainly something that we look at. Some of the anticonvulsant medicines like gabapentin, even carbamazepine or Tegretol, sometimes can have an effect on spasticity. They probably work a little bit better for the waves of muscle cramping or spasms, more so than the chronic state of increased muscle tone or spasticity. So a lot of different medications in the toolbox that we can look at as potential treatment options. What if those are not enough? There are some special tools that the rehab docs have, something called serial casting. So if you have a leg that is, or an arm that's really, really tight, and maybe you've developed contractures. Contractures are when the muscle has been in a state of tightness for so long that the muscle has shortened in length, the tendons are a little bit shorter in length, and it's very difficult to do range of motion in that individual. It's difficult to get past that even with medications. So serial casting would mean stretching that muscle out just a little bit, putting a cast on just as if you had a fracture, and leaving that cast on for a short period of time, maybe a week or so, bring the individual back in, take that cast off, put another one on that stretches that muscle out just a little bit more, so that over a period of time, maybe you can lengthen that muscle and tendon, so that now maybe some of the lower steps on the ladder may have a better chance of working for you. If a particular muscle is involved with spasticity or spasms, you might be a candidate for Botox injections. So Botox injections are done to really relax that muscle. You would have to do this in muscles that are not going to affect your activities of daily living, because Botox works to temporarily paralyze that muscle. So if it's a muscle that you need to take care of your daily activities, we obviously don't want to paralyze that. But again, in certain situations with certain muscles, the Botox injections can be a good thing. Different sorts of splints, so maybe hand splints at night if your fingers want to tend to tighten up, foot splints, ankle splints, just to try to keep those muscles in a more favorable position, are all some of the tools that the physical therapists have in their, and the occupational therapists have in their toolbox. One of the other tools that is available for people maybe that have not responded to traditional treatments would be intrathecal baclofen. So this would be administering the baclofen via a surgically implanted pump directly into the spinal fluid. What doing this allows is for a very concentrated liquid dose of the baclofen, sort of really working primarily where you want it working, and that's at the spinal cord. When we take baclofen by mouth, a certain amount of it, after it's absorbed to the GI tract, goes to the liver. That part's metabolized, and you never benefit from it, so it's just excreted. A certain amount goes into the brain itself. That's not where we want baclofen working. Baclofen in the brain itself is where we see the sedation coming from. We really, again, want it just working at the spinal cord level. So what if you could just deliver concentrated liquid baclofen to the spinal cord itself? Most people are not going to be very excited about coming in for a weekly spinal tap to get baclofen injected. So this is where the pump comes into play. And there are two companies that make a surgically implanted pump. And because it is a surgery, it's kind of a big deal for the person to undergo. You want to make sure that you're going to get everything out of that surgically implanted pump that you want to before you commit to it. So this is called a baclofen pump trial. So through a team of physicians, if they feel that you're appropriate for one of these pumps, they'll set you up to actually see if you're going to get everything you want out of that. And that can be done in one of two ways. They can admit you to the hospital and do a spinal tap or lumbar puncture and give you a test dose of this concentrated liquid baclofen. It's going to last for a while. You'll get a sense of whether it's doing what you want it to do. The other way that a baclofen pump trial can be done is through a temporary pump that's placed. So this is a catheter that's put in place. Then you would go home with a temporary pump. These are sometimes done for a 24-hour trial so that you probably get a much better sense in your environment as to whether this is going to do what you want it to do. These pumps typically will hold somewhere between 3-4 months worth of that concentrated liquid baclofen. They're programmable so they can be set at different rates to deliver different amounts of the baclofen. You go back in every few months to have the reservoir in the pump refilled. This is done through it's a shot, basically. They can access the pump just through an injection at the skin. The pump itself is going to be down on your side, right above your belt line, typically. Unless you're just really, really thin, these are usually not obvious in any way. With pumps nowadays, we can do MRIs. That was sometimes a challenge way back in the days when the pumps first came out. But the pumps are generally MRI compatible. If you have an MRI and you have one of these pumps in place, we do a pump interrogation after the MRI, and that means you'll come over to clinic and the nurses will be able to make sure that the magnet in the MRI has not actually altered the settings of the pump in any way, and that you're still safe to go home with that pump in. Those pumps may need to be replaced every few years. I've seen pumps go 6 or 7 years before they need to be replaced. Generally, the complication rate is low. Like with any surgery, there's always the risk of infections. There's the risk of the general anesthetic itself. Rarely these pumps malfunction. I would say that's very, very unusual. They've been around for quite a while now, and so there are a lot of safeguards that have been put in place with these pumps. So that would be kind of the range of what we've traditionally thought of treatment and spasticity. A topic that, and we did a talk a couple of months ago at Shepherd Center on cannabinoids, or how the active ingredients in marijuana products, do they play a role in MS management? And when we're thinking of cannabinoids, one of the symptoms that would commonly be mentioned would be spasticity. So the active ingredients in cannabis or marijuana, one of the active ingredients is a class of chemicals called cannabinoids. There's another class of ingredients called terpenes, but most of our research, I would say the body of research, has been on cannabinoids. The two that probably have been looked at the most are THC and CBD. 42 states of the union now have some sort of medical marijuana law in place. Most of these laws include multiple sclerosis as one of the conditions that might be a candidate for treatment. The challenge that we have right now is that we really are a patchwork of different state laws, and many of these state laws seem to conflict with the federal laws. So it's really worth looking at what your local state laws are, working with your healthcare providers to see if this is an option for you. The literature is somewhat confusing in multiple sclerosis. I would say that the bottom line is, when you look at all of the studies of cannabinoids in multiple sclerosis spasticity management, the weight of the evidence would argue that there is something there, that they do seem to have a calming effect on spasms and spasticity as it is experienced by the person with MS. One of the curious things is that what these studies show is that people feel better, that their spasms are less, their reported pain is less. One of the scales that we use to measure spasticity objectively in research is called the Ashworth scale. Most of these studies have not shown a dramatic effect on the Ashworth scale. So there's this interesting sort of dichotomy between people feeling better and the objective measure that at least research has accepted, maybe not reflecting that. For me, as a healthcare provider, at the end of the day, I'm most interested in people functioning better and feeling better. It could be that our scale that we're using, the Ashworth scale, maybe it's just not sensitive enough to measure really what we want it to measure. It's hard to make any blanket statements because we may have listeners from states all over the country. It's hard to make a blanket statement about what the legalities of cannabinoids would be in your specific area. But if you're having a difficult time with spasticity and spasms and you have exhausted all of the conventional measures, it certainly would be something that's in the toolbox to look at as a treatment option. So I think, again, spasticity and spasms is a topic we probably should focus a little bit more on. Sometimes we put it into the bigger topic of gait issues or mobility issues. It's certainly something that can affect walking, and I think in a perfect world, everyone would have access to a comprehensive team where you would have your neurologist talking to your therapist, talking to your physical medicine and rehab people, talking to your exercise person, because everyone, I think, has a place at the table in managing spasticity as it affects the person with multiple sclerosis. And with that, I'm going to stop formally talking and throw it open to questions and hopefully answers online. So, Casey, if you want to help me out here, and we'll see what we've got out there.
Okay. I'm looking at the number of people who have actually logged on the internet to ask questions, and I see that not a lot of folks who are on the line have been able to do that. So I'm going to try something unconventional, and I'm going to unmute everyone. We have a relatively small group tonight, and I know that some of you probably have questions. So what we're going to do is I'm going to take everyone off mute. If you would like to mute your own line after I do so, hit *6 to mute your line. If you have a question or a comment for Dr. Thrower, then obviously don't mute your line. Go ahead and ask, and let's try and be respectful and everybody not speak over anybody else. So I'm going to take everyone off mute now.
The conference is no longer in listen-only mode.
Okay, so again, everyone, if you would like to put your own line on mute, if you have a dog barking or TV going, you can press *6 to do that. So who has a question for Dr. Ben?
I'm Kathy Crudell, and I have a question.
Hi,
Go
Kathy.
ahead, Kathy.
Hi, Casey, and hi, Dr. Ben. I don't know if you remember me, but
Absolutely, I remember you.
Oh, good.
Yeah.
I wish I lived in Atlanta, although my daughter does, so who knows, maybe one day I'll become your patient.
Absolutely.
So, obviously, I have MS, but I also want to mention I'm an MSF ambassador, and I'm so honored to be one. So if anybody out there is applying for one, it's one of the most wonderful things in my life. And I wanted to ask you a question. I am getting ready, I don't know how soon, but I'm walking around with my knee bone on bone, which I can barely walk. And unfortunately, the doctor that I went to, when I mentioned, I mean, it's pretty obvious I have something wrong with me. When I mentioned that I had MS, he said, "Oh, gee, I've never worked on anybody that has MS." So I said, well, I had a knee replacement in 2011, and I did really well. Unfortunately, my doctor had retired. I mean, I didn't say to him that, but my doctor did retire, and he had never worked on anybody that had MS with a total knee replacement. But he said, you know, I'll keep in touch with your doctor. You're going to do fine. And I did. But so now I'm in Rhode Island like a man without a country, because I went to the doctor last week until I can get to Boston, and he gave me a cortisone shot, and that didn't help at all. And then I went back to him, and he said he has a series of 3 shots he can give me, but he's not sure even that will help. In the meantime, I do have an appointment with the doctor in Boston, but not until the 27th. So just the thought of having those shots that might not help me, right away I started getting spasms in my leg. I don't know if it's psychological or what. But when I'm not taking medication for my pain, which I don't like taking, my leg will start getting spasms. I stretch, I go to physical therapy until I can get to that doctor in Boston. But in the meantime, I'm in excruciating pain. And I don't know, do you have any suggestions for that? The shot is called Uflexerol, but I'm waiting to get in touch with my MS doctor, and he's away, and I'm scheduled to get my first shot on Wednesday. But with this orthopedic surgeon, he doesn't seem to know much about MS, and I don't want my leg to get worse. I mean, I don't know if you can answer that question for me.
So the good news is that when we think about, you know, the sort of post-operative, perioperative issues, whether it's a knee replacement or any other surgery, really, the issues of general anesthetic, your post-operative care really are no different in regards to the anesthetic. So the surgeon should be reassured that you know, there's really nothing differently that they need to do. Where things are going to be different is in the post-operative phase with rehabilitation. So you're going to need, you know, fairly proactive and aggressive rehabilitation if you do have a total knee replacement. The good news is you've been down this path before. You know kind of what to expect.
Mm-hmm.
There, generally with knee replacements, what most orthopedic surgeons feel is that you're going to tell them when it's time. They will basically let you put up with as much discomfort as you want to put up with until you say, enough's enough, do the surgery. I suspect that the injections that they're talking about doing, he may have thought about that just maybe because he's a little more nervous about working with someone with MS. There's not a big downside to trying the injections. Whether it works or not, I think is going to be trial and error. I don't think you're hurting anything by trying those out, other than just the discomfort of maybe prolonging the time that you have to have surgery. So what you're dealing with right now would be a great example of a noxious stimulus. If your knee is hurting, it's going to kick off spasms, and taking care of the underlying problem. Obviously, it's not going to get rid of all of your spasticity, but it's going to probably help out significantly with your walking and your spasticity overall. So there's nothing wrong with if you have been using baclofen or tizanidine or something like that, of keeping that up throughout this this period of time, because I think you're dealing with two issues. You've got the orthopedic issue and then your underlying MS spasticity, and the orthopedic issue is certainly making your spasticity kick up right now. I would suspect that ultimately you probably are headed towards another total knee replacement, and maybe the injections are going to buy you some time. But if there's a silver lining, again, it's the general anesthetic and all of the perioperative stuff other than rehabilitation is not really any different for a person with MS. The good news also is that generally surgeries for most people with MS don't provoke relapses. If you had a postoperative infection, it's going to make your neurological symptoms worse, but true relapses are not very common after general surgeries.
Mm-hmm. I did very well with my first one, but even before I left the doctors, this doctor, he said to my husband and myself, I can give you the name of some other doctors if you would like. And I just stood there, and right now I'm kind of at his mercy till I get to Boston. But with that being said, I don't think I really want him to do surgery on my leg if he's that nervous about me having MS.
You've got to be comfortable, and I would say whatever surgeon you end up with, you might have them just touch bases with your MS doctor too, just for some reassurance.
Mm-hmm. So I think I'm going to pack I'll pack my things and come down to Atlanta, Doctor.
There you go. Good to hear from you, Kathy.
Thank you for that question, Kathy. Does anyone else have a question for Dr. Thorne?
Thank you.
Yes, I do. Are you there?
I am.
Yes.
Yep.
Okay, hi. My name is Wendy Richards, and in 2012, I got a baclofen pump put in, and totally accidentally, I was given too much baclofen in my pump, and I don't want to scare anybody. The pumps are awesome. My epiphany is a complete rarity. I got too much baclofen in my pump, and within 6 months, my strength went down to zero, and my feeling, I went from being no feeling from my waist down to my chest. I ended up bedridden for 3.5 years. Well, one day I got this feeling back, just out of the blue. It just came back, strength came back. I'm now in rehab, and I'm getting back to my core strength and everything that I lost. Before this, I was able to live on my own, transfer on my own. With this spasticity, it helped me actually transferring. Now my legs are so weak, I can't use them for transferring. Do you know if I have proper equipment for the legs, maybe I can build some of that strength back up and be able to use my legs for transferring again, get some of that spasticity back?
Yeah.
That's a
So
weird question.
Well, thanks, Wendy. So, baclofen pumps do require people to get the adjustment just right, and so there's not only the settings, but it's the concentration of the liquid baclofen that is put in. So I have one individual that I work with, a young woman that had a similar experience that we don't know quite what happened, but with one of her pump adjustments, she got extremely weak after that and really stayed that way for quite some time. It is possible to potentially build strength back up. So one of the things that the therapists that I work with make a great point of is that when you look at a person with MS in terms of their level of functioning, in their disability, some of their disability is damage in the brain and spinal cord from their multiple sclerosis. Some is probably deconditioning. So from the period of time you've been weak, you probably, those muscles are significantly deconditioned. That deconditioning part of the bucket is the part of your disability that may be reversible, or at least it could be potentially improved upon. And so we want to be really aggressive in trying to give people every chance that they can to be as strong as they can be. So how do you move your legs and try to get some strength back? The aquatics programs would be one way that we can unweight your legs and potentially have a therapist work with you in an unweighted situation. We have a piece of equipment at Shepherd, and I know other facilities have this, called the Alter G. There's another piece of equipment called Zero G. These are zero-gravity treadmills where we can take away your body weight and potentially let you move your legs again. There's another piece of equipment similar to that called the Locomat, which is a robotic treadmill. It's used for people with multiple sclerosis. It's used for people with spinal cord injuries who are paraplegic, where we can put you in this robotic sort of treadmill that will move your legs for you if you can't move them. Another way of getting your legs moving if you're having significant weakness would be with something called FES bike, or functional electrical stimulation bicycles. Our lead researcher at Shepherd Center, Dr. Backus, this is an area she's very interested in. So this is you're on a mechanical bike that you could pedal, but also you have electrodes then on your legs that if you are not able to pedal, they may fire your muscles for you, or the motor in the bicycle may pick up and help you move those. We never know, in a given individual, which of those things might be most appropriate to try to start getting some strength back in the legs, but there are tools out there to be used for people like yourself.
Okay, I'm coming back to see you, and that's where I'm at right now, where I'm building up my
So we should look at all those things. Yeah.
But I'm coming back to see if you rock and you're the best. And I'm like, help me get my legs going. It's you.
Let's look at all of those things. We'll get you in with the rehab folks and let them start working on those.
Oh, thank you for the encouragement, though.
Absolutely. You hang in there. Good to hear from you.
I will. Thank you. You too.
Okay. Does anyone else have a question for Dr. Thrower?
I have a question.
Go ahead.
Okay. I'm sorry about my barking dog. I'm in Eastern North Carolina. My name is Anna. We were having a little bit of a thunderstorm. I have flare-ups from time to time, and I need help with my strengthening exercises to a certain point. And when I don't get it, and I don't get my passive stretching, my spasticity gets a lot worse. And they were going to put a baclofen pump in the last time I was in the hospital, but because they said I did deserve the chance to try to regain some of my strength and functionality, because the pump would have made me more dependent, more flaccid. But range of motion in the morning broke up that spasticity in my legs, and the passive stretching helped me be able to stay alone at night without having to worry about falling or sliding off or spasming out of my wheelchair, because I'm a quadriplegic. And I'm able to to transfer independently without a sliding board. I can bear weight when I'm home by myself at night. Is there any chance and North Carolina has does not offer enough rehab for somebody with multiple sclerosis anymore if you have Medicaid and Medicare? And is there any chance that the nurses some of the nurses refused to do the range of motion? And I had for my physical therapy, sometimes I had to choose between stretching or strengthening or trying to regain some of my strength. Is there any chance that at least range of motion and maybe passive stretching might become a necessary skill for nurses and nurses' aides or care partners for certified? Because that helped a great deal with my spasticity and with my baclofen regimen that they put me on. I don't require the pump, and I'm not flaccid, like they said the pump would have made me.
Right, and it's frustrating because you clearly medically need range of motion, the passive range of motion therapy, and because without it, I mean, you're at risk for so many complications. We see more potential
and more
skin break.
expensive medical care for the government to pay for.
That's absolutely right, and it's frustrating sometimes when Medicare, Medicaid, different, even private insurances don't get that they could spend a little bit here and prevent a lot of problems for you and financial issues for themselves down the line. Which city are you in North Carolina?
I'm in Greenville, North Carolina.
So, I mean, I would certainly talk to if there's a support group there, either through the MS Foundation, the National MS Society, through the MSAA, if you could reach out to them online and find out who the physical therapists are there that might be able to do more care. I know in Charlotte, you've got the Carolinas Medical Center. There is a good comprehensive MS center there. I know it's a little bit of a haul for you. My family's in Charlotte, so we drive up through your way frequently. So that's another couple of hours up to Charlotte. But it might be worth looking at what sort of rehab services they offer up there. I know for us, you're about the same distance between us and Charlotte, and we do have the day program at Shepherd Center that you would certainly be a candidate for, and that's where you would come in and have caregivers actually trained and working with you individually. That's about a 2-week program, and the housing is actually provided free of charge through Shepherd Center on site.
The part of the conference. Where is the Shepherd Center?
So we're in Atlanta. Yeah.
Okay.
So just down the road, down 85 from you. And Casey, are you still on the line?
Yes.
So in terms of getting, financial help for grants for, home care, are there other suggestions you would have, places people can reach out to?
Absolutely. There are cases where we do cover rehabilitative services through the home care grant, physical therapy, occupational therapy, and speech therapy. And people who are in need of those services can find out more or apply online at www.msfocus.org, or they can give us a call at 888-MS-FOCUS and speak to a caseworker in the home care department.
Wonderful. Thank you.
And ma'am, from our standpoint, if you reached out to Shepherd Center, if you asked for our lead case manager, Lisa Lundy, Lundy, she could give you more information on ways that we might be able to help out also.
Very good. Thank you.
You're welcome.
All right. Well, that's all our questions for now then. I'd like to thank you all for your participation. That was several really great questions. Really appreciate your joining in. So I'd like to remind everybody, if you missed any part of this program, it will be rebroadcast on msfocusradio.org and available on demand. You can follow the Multiple Sclerosis Foundation on Facebook, Twitter, or Instagram to get times and access information. And to learn more about Spasticity Awareness Week, please visit www.spasticityalliance.org. Our sincere thanks to all of you for your support. We appreciate you joining us, and especially to Dr. Ben Thrower. Thank you so much for a wonderful presentation and the time you've taken to answer all of these questions. We really appreciate it.
Thank you, Casey, and thank you to everyone out there who joined in with us tonight. And sorry we didn't get to the dog's question because he sounded like he had a burning question.
He wanted the thunder to stop. I've tried everything, noise reducers. I don't want to take up your time, but it's a matter.
We'll get the dog on next time.
Well, that's it for this
Thank you,
program.
everybody.
So thank you, everyone, and good night.